attending this conference. The topic of my presentation is considerations on the concept, definition, and diagnosis of amyotrophic lateral sclerosis. I come from Jiangxi Province People's Hospital. My name is Ren Xu. First, we will talk about background of ALS. The concept, definition, and diagnosis of amyotrophic lateral sclerosis currently present some problems. We systematically review the literature on the history, current concepts, definition, and diagnosis of ALS, and disclose the present problems based on the retrieved literature and our clinical experience. The current concepts and definitions of ALS have not yet been unified or standardized in clinical practice, and are sometimes vague or inaccurate, which can cause difficulty for neurologists in the clinical treatment of ALS. The concept and definition of ALS need to be phased as same need, and the current diagnostic criteria for ALS require phased development. The identification of effective and objective biomarkers may be a feasible method for the early and accurate diagnosis of ALS. Manifestations about ALS. Pathologies: muscle weakness and atrophy caused by the degeneration of both upper motor neurons and lower motor neurons, like this picture shows. Signs of ALS: progressive stiffness, convergence, and worsening, muscle weakness, and voluntary movement. Major symptoms of ALS included difficulty in speech, dysphagia, and involuntary dyspnea. Some ALS patients also present mind cognitive or behavioral dysfunction in the mind and or later stages. Sensory nervous and autonomic nervous system are unaffected. Epidemiology of ALS. ALS can affect people of any age, but usually occurs around the age of 60 years old. The survival time from morbidity to death in most ALS patients is usually 3 to 5 years. Approximately 10% of AS patients survive for longer than 10 years after clinic onset. Most AS patients die of respiratory failure within 5 years after clinic onset. In many countries, the current incidence of AS is unclear. In the European, American, and Chinese populations, the incidence rates of AS are around 2 people per 100,000 per year. Etiology of AS. The etiology AS about 19 to 95 of AS remains unknown. This picture shows the possible etiology about AS. For example, glutamatergic excitotoxicity, neuroinflammation, nuclear RNA dysregulation, cytoplasmic RNA and protein dysregulation, mitochondrial dysfunction, and so on. 5 to 10% of AS patients have inherited familial forms of the disease. The current treatment of AS. At present, there are no treatments that can cure AS. Reduction may be extend patients' life space by 2 to 3 months. Endeavours, a reactive oxygen species scavenging mid-phase clinic verification in large trials of AS patients and atrophy throughout the body. Other drugs such as sodium phenylbutyrate and taurosodiol toxin for SOD1 mutation patients. Such strategy for this study. We check the literature review was performed with strict control of the data. Keywords: amyotrophic lateral sclerosis, muscle atrophy, motor neuron disease, familial AS, history, concept, definition, clinic, symptom, diagnosis, and question. Databases: PubMed, Google, OneFound, and in various medical guidelines. Time period from the beginning to May 2020. Current related problem was analyzed based on the retrieved literature as well as difficulties that we have encountered in our clinical work. Problem in definitions. The concept and definitions of the AS and MND are not unified. worldwide. ALS is sometimes called motor neuron disease. In common with countries, the term MND is commonly used instead of ALS. However, the other countries usually use the concept and definitions of ALS. They concede that ALS is a subtype of MND. The concept and definition of ALS and MND are mixed and are used in many research studies and clinical work. The current concept and definition of both ALS and MND are somewhat deficient in accurately describing the disease. The concept and the definition of ALS are based on the pathological concept and the definition of ALS have not yet been unified or named, which states that ALS is a disease combining muscle strain the disease in clinical practice and is sometimes vague or inaccurate. The original concept and definition of ALS may be inappropriate for both research and clinical work. The primary concept and definition of ALS is that it is a disease that damages motor neurons of the brain, brainstem, and the spinal cord at the same time. However, with the progression of ALS research, it has become apparent that ALS is rapidly progressive and fatal disease that not only affects motor neuron in the cerebrum, brainstem, and spinal cord that control voluntary muscle movement, but also damages some neurons associated with cognitive and behavioral function. Some countries divided MND into 4 subtypes: ALS, primary lateral sclerosis, progressive muscular atrophy, and progressive Bible palsy. Both ALS and PAS are pathological concepts and definitions. In contrast, PMA and PBP are defined according to clinical symptoms and signs. However, we have found that some patients who are diagnosed early with PAS or PBP can ultimately develop into ALS in the middle or late stages of the disease, suggesting that different MND subtypes may be different manifestations of ALS rather than independent disease, at least in most patients. Based on these problems, we believe that the concept and definition of ALS should be updated and reconsidered. We propose that the current concept and definitions of AS and MND are not accurate, and that it is not scientifically valid to include AS as a subtype of MND. For example, we also suggested that Bell Chapter's disease is the better name for AS, so that it is named after the scientists who first described the disease in accordance with international convention similar to Parkinson's disease and Alzheimer's disease. If we continue to use the current concept and definition of AS in clinical and research work, it is likely to produce misunderstandings because AS is defined as a disease that merely damages upper motor neuron and lower motor neurons. Moreover, AS cannot currently be diagnosed if it is accompanied by lesions in no motor neurons. It is inappropriate to consider AS as a subtype of MND because MND is a group of diseases that only damage motor neuron and no motor neurons. Moreover, according to the 2015 revised EIS criteria, the other three subtypes of MND might merely be different onset types or stages of AS. Most MND might ultimately involve damage to both upper motor neuron and lower motor neuron and develop into AS. To date, there is no clear evidence about whether or not the different subtypes of MND are independent diseases, each with an independent pathogenesis. In 1994, the EIS diagnostic criteria have been recognized as the most useful diagnostic criteria for selecting patients for research trials. However, generally, neurologists and neuromuscular clinicians often find these criteria unweighted and generally unhelpful for achieving an earlier diagnosis of AS. In 2000, the EIS revised was a step toward improved AS diagnostic criteria and the diagnostic rate of AS patients. That allows clinicians more latitude for beginning AS treatment. However, the accurate diagnosis is a difficult problem that continues to challenge neuromuscular specialists. Earlier diagnosis of AS based on its progressive and late appearing clinical manifestations will require more substantial advanced in the fields of electrical diagnosis, neuroimaging, immunobiochemistry, and neurogenetics. In 2008, the Awagi criteria for the diagnosis of ALS was proposed, with some new auxiliary tests. As well, the importance of the neurophysiologic data was emphasized. However, in these criteria, we believe that use the Awagi criteria can lead to the false positive diagnosis of ALS, because vasculation potentials associated with signs of the innervation are considered evidence of low motor neural lesions, in particular in cranial innervated or strong limbo muscles. In 2015, the ELS criteria, the newest criteria, was proposed. However, in these criteria, we believe that diagnosing ALS on the basis of prominent abnormalities in cognition, sensory nervous conduction, the oculomotor system, and sophisticated function is likely to lead to the false positive diagnosis of ALS, especially in the early stage of ALS. Based on the current diagnostic criteria, multifocal motor neuropathy is the most frequent disorder to the misdiagnosed as ALS, followed by Kennedy's disease. The present diagnostic criteria of ALS lack useful clinical auxiliary diagnostic tests. Neurologists generally make an ALS diagnosis majorly depending on the clinical symptoms and the signs of upper motor neuron and lower motor neuron yet. Clinical trial investigators enroll patients with ALS according to the 1998 revised ELS criteria, which might bring some problem with distractiveness and sensitivity. Most ALS patients would go undiagnosed if the ELS revised was used in the earlier diagnosis of ALS, because the majority of ALS patients only present with clinical signs or symptoms in one or two regions, or present with pure muscle atrophy or only a lateral funiculus lesion. To date, there are no definitive diagnostic tests or genetic biomarkers for diagnosing ALS. The use of current diagnostic technology make it very difficult to obtain an early and accurate diagnosis of ALS. They are likely to produce many false negative and false positive diagnoses of ALS. Also, transcranial magnetic stimulation, focal-based morphometry, and diffusion tensor imaging can be used to detect lateral funiculus lesions, but cannot effectively and objectively detect lateral funiculus sclerosis phenotype in severe ALS patients. EMG only detects low motor neural damage and is not sensitive or definitive for identifying upper motor neural damage. Therefore, the current estimation of upper motor neural lesions may, depending on patients' clinical manifestations, including elevated muscle tension, hyperfunction of tendon reflex, and pathological signs. The current diagnostic criteria of ALS may depending on clinical manifestations and aside from EMG. There are no objective auxiliary technologies for the diagnosis of this disease. Other examination methods, including computed tomography, MRI, and some laboratory tests, are generally used for differential diagnosis only. Proposal for improve the current diagnosis of ALS. Firstly, it must be distinguished from a legion of ALS mimicking syndromes that have a similar clinical manifestation to ALS in the area healed by the clinic auxiliary tests, such as the laboratory test and imaging examination. Secondly, I propose that a genetic test should be routinely conducted to exclude ALS-like genetic disease in the differentiation diagnosis of ALS. This is especially important for the early diagnosis of ALS. In case of pure low motor neural lesions, a genetic test is an important measure for differentiation Kennedy's disease, X-linked spinal atrophy, and spinal muscular atrophy. Of course, the spatial diagnostic biomarker is an ideal diagnostic measure. This is my presentation. I hope every professor and colleges give me the good suggestion to improve the opinion and research in future. Thank you for your attention.
Primary Education Service, Area Office, Thailand. Today, I'm here to present about development of silent activities package using by STEM education in conjunction with collaborative learning, effective Prathomsuksa by students, creative problem solving, teamwork skill, and learning achievement. Education is the process of human development to progress. Quality education will result in humans developing higher quality of themselves. Learning and self-development occur throughout life. This will affect the development of the nation, especially countries that have advanced science and technology. They are often countries that are economic leaders as well. Advance in science help develop human life to be more comfortable. There are modern tools and appliances because science helps develop human thinking to be a reasonable person, have analytical thinking, think critically and creatively. In addition, science creates more knowledge and understanding of nature and phenomena. Developing the country to have the potential to compete with other countries. It is necessary to strengthen the scientific knowledge of the people. Education is preparing people to live in society of science and technology, but as producers and as smart consumers. The skills needed to learn in the 21st century are called 3R and AC. 3R such as reading, writing, arithmetic, and AC such as critical thinking and solving problems, creativity and innovation, collaboration, teamwork, and leadership, cross-cultural understanding, communication, information, and media literacy, computing, media literacy, career, and learning self. Creative problem solving. Creative problem solving is a way of solving problems or identifying opportunities when conventional thinking has failed. It encourages you to find fresh perspectives and come up with innovative solutions so that you can formulate a plan to overcome obstacles and reach your goal. Creative problem solving is the process of resolving obstacles or situations that are oppressive, obstructive, that make it impossible to reach the goal that have been set with least possible impact. Problem solving is an important process that humans use to survive, including adapting to the situation. There are not always precise steps to solving a problem. Different strategies may be used to resolve the problem. Teamwork skills are work together to work. The same goal group members have different responsibility, but work must be driven simultaneously. Working as a team therefore requires cooperation, unity, and reliance on one another, accepting opinion. Members have common goals, respect for each other's abilities, cooperation and unity in working together, division of duty according to ability, responsible. Problem in science, learning management compound with one teacher, learning management, and student. Problem in teacher. The problem for teacher is that the format for management learning activity is not diverse. There is no knowledge, lack of training in thinking process skill for students and preparation for teaching. Learning management. The learning process does not emphasize group activities or teamwork for students. They do not practice solving problems in situations related to daily life. Students lack the skill to acquire knowledge on their own. Lack of creative thinking. Prefer working alone more than working in group. Lack of interaction between students. STEM education is an approach to education that integrates science, engineering, technology, and mathematics. Emphasis is placed on applying knowledge to solve real-life problems, include the development of new processes or products that are benefit to living and working. And cooperative learning. Cooperative learning is an instructional method in which students work in small groups to accomplish a common learning goal with the guidance of the teacher. So, learning management model according to STEM education and cooperative learning is from the train student to understand the principle of thinking, systematically advanced thinking and creative problem solving, train students to understand the process of searching for answer on their own, practice thinking and solving problems in various situations with creative bliss, teamwork to achieve the learning goal. Research objective. The student was conducted to investigate the development of science learning activity package using by STEM education in conjunction with collaborative learning, effective Prathomsuksa 5 student creative problem solving, teamwork skill, and learning achievement. Select by cluster random sampling. The subject were Prathomsuksa 5 students who enrolled the second semester. The 2018 academic year at Bangkok School under Mukdahan Primary Education Service of Area Office. The research objective 1, to find the effectiveness of science learning activities set on force and pressure of students in grade 5 by organized learning activity according to STEM education, together with cooperative learning, effective according to the criteria 75/75. 2, to compare creative problem solving between before class and after class with a set of science learning activity according to STEM education together with cooperative learning of the 5th grade student. 3, to compare teamwork skill between before class and after class with the set of science learning activity according to STEM education together with cooperative learning of the 5th grade student. Number 4, to compare academic achievement in science subjects between before class and after class with a set of science learning activity according to STEM education together with cooperative learning of the 5th grade student. Number 5, to compare creative problem solving and academic achievement between students with different science process skill, high, medium, and low, when learning with a set of science learning activity according to STEM education together with cooperative learning. Methodologies, population and sample group. Population used in this research is a 50 grade student at school in Kamsayna Udom Network Group, under Mukdahan Primary Education Service Area Office, currently student studying in the first semester of academic years, 2018 number of students 283 from 10 schools. Sample group. The sample group are used in research were 5th grade students of Banpata School under Mukdahan Primary Education Service Area Office who are studying in the first semester of the 2018 academic year. The number of students is 18, obtained by cluster random sampling using the classroom as unit of random sampling. Research instrument. Instruments used in this study conclude: 1. The science learning activity package constructed by STEM education in conjunction with collaborative learning. 2. The creative problem-solving ability in science tests. 3. The student teamwork evaluation form. 4. The student learning achievement test. 5. The science process skill test. The statistics used for data analysis. The statistics used for data analysis were composed of mean, standard deviation, efficiency value, t-test for dependent samples, t-test for one samples, analysis of variance, ANOVA, multivariate, analysis of covariant MoCA, and analysis of covariant and COVA. The result of research. Number 1, the efficiency value of learning activity package on the science learning activity package constructed by STEM education in conjunction with collaborative learning were 90.54/87.440, which were higher than the standard criteria. 2. The student creative problem solving who learning through the science learning activity package constructed by STEM education in conjunction with collaborative learning after studying was higher than before studying, statistically significant at 0.05 level. 3. The student teamwork skill who learning through science learning activity package constructed by STEM education in conjunction with collaborative learning after studying was higher than the standard criteria, statistically significant at 0.05 level. 4. The student learning achievement who learning through the science learning activity package constructed by STEM education in conjunction with the collaborative learning after studying was higher than before studying, statistically significant at 0.05 level. 5. When subdividing the science process skill of student 3 levels at the high, moderate, and low, it was found that the creative problem-solving ability and teamwork skill of the students who learning through the science learning activity package constructed by STEM education in conjunction with collaborative learning. After studying what higher than before study, statistically significant at 0.05 level, in which students with high level of science process skill have creative problem-solving abilities and higher teamwork skills, moderate and low group respectively, and medium group were higher than low group as the academic achievement student with high level of science process skill, moderate and low level had no difference in academic achievement after learning. The research was successfully completed because I received partners from Assistant Professor Dr. Marasi Kamprapan, Chairman in an advisory committee member, and Dr. Somkiat Palajit, an advisory committee member who kindly provide advice, recommendation, and assistance in the investigation and improve and feedback. As a result, the research was successfully completed. I'm grateful for your kindness and would like to thank you very much for your opportunities. Thank you for your attention and participation. I am open to further discussion or feedback. Thank you, everyone.
And today I will present you my specialty thesis in child and adolescent psychiatry. Turkish adaptation and validation of behavioral inhibition questionnaire parent form. This is my outline. Firstly, background, then our objective, methods, results, and discussion, and conclusions. As a start, temperament is a set of behavioral tendencies that can be observed from early infancy, like genetic determinant, that affect how an individual approach and reacts to others. Situation and is a tendency to show hyperarousal, cowardice, and shyness in the face of unfamiliar or new people, object, environment, and situations. Behavioral inhibition is a highly inhibited category, can be observed in approximately 10% of childhood. And it is one of the strongest risk factors for development of anxiety disorders, especially social anxiety disorder. And it has been found that the risk of developing any anxiety disorder is 4 times higher in individuals with behavioral inhibition than in those without. Approximately half of the children with behavioral inhibition do not develop an anxiety disorder. So this risk may be regulated by various external and internal factors, such as parental attitudes and information processing function of the child. Therefore, determining the presence of behavioral inhibition in early childhood and applying early interventions are important in terms of preventive mental health. How can we assess behavioral inhibition? One of the assessment procedure is observational procedures. Firstly, Jerome Kagan, behavioral inhibition paradigm he developed for infants, and then modified version of the behavioral inhibition paradigm for preschoolers, and laboratory temperament assessment battery inhibition subscales were developed. Also, multi-method assessment of social inhibition and behavioral inhibition observation system by Ballasby were developed. But the procedure have not been standardized across laboratories except for lab tech. Observational procedures are expensive, time-consuming, not ecologically validated, usually developed and tested in American population. Questionnaires are the another way of assessment of behavioral inhibition, and they are based on caregiver and teacher reports. Behavioral inhibition questionnaire was developed by Bishop and her friends, and then preschool behavioral inhibition scale for 3 and 6-year-old children were developed by Ballasby. Preschool behavioral inhibition scale and behavioral inhibition scale for 3 and 6-year-old children were assessing only the social dimension of behavioral inhibition, and they considered behavioral inhibition as a concept similar to shyness. Behavioral inhibition questionnaire differently is a measuring tool that assesses behavioral inhibition in a manner that aligns with its multidimensional structure. It includes both social and non-social situations and is designed with a 6-dimensional scale structure. Assess the child's reaction to unfamiliar adults, reaction to unfamiliar peers, entry into separation from caregivers, nursery, preschool settings, performance situation, response to physical challenge, reaction to new situation. The parent form consists of 7-point Likert scale with 30 items, while the teacher form comprises 28 items without questions related to the child's behavior in unfamiliar households. The total score of behavioral inhibition questionnaire ranges from 30 to 210, with the highest score indicating the highest level of inhibition. It is cost-effective and time-efficient compared to observational methods, providing a broader perspective of information through different situations in different settings which the behavior is exhibited. Validity and reliability confirmed through testing in different populations. And then, why should behavioral inhibition questionnaire be introduced to Turkish? Studies on behavioral inhibition as a temperamental trait in Turkey so limited that there are only 3 master studies conducted in adulthood. In preschool, middle childhood, and adolescent, there is no study directly addressing the concept of behavioral inhibition. In the case of children and adolescents, studies have been limited to an assessment methods that focus on the shyness traits, either directly or by reverse scoring the subdimensions of basic temperament scales or extraversion subdimensions. The inadequacy of studies related to behavioral inhibition in children and adolescents and the failure of existing studies in adulthood to evaluate the behavioral inhibition personality trait in a genuine and original manner indicate the need for a Turkish assessment tool for behavioral inhibition. Here is our objective: validating and determining the reliability of the behavioral inhibition questionnaire parent form for children aged 3-7 in Turkish population. Research sample, 250 mothers or fathers where children aged 3 or 7 attending the first grade of primary school and preschool affiliated with the same school in 2 different central districts of Konya City filled out the scales for their children and, if available, their younger siblings. The inclusion criteria were children aged 3 and 7 and parents with at least a primary school education, while no exclusion criteria were applied. Approximately 50 questionnaires were excluded due to a substantial amount of missing data or the determination they were not reliably filled out. Data collection tools, socio-demographic data form, behavioral inhibition questionnaire parent form in Turkish, child behavior checklist short form, strengths and difficulties questionnaire. Firstly, translation and adaptation of behavioral inhibition questionnaire into Turkish, visiting 3 elementary schools in Konya in Turkey, distributing questionnaires to parents through teachers. The consent was taken as written, socio-demographic data form, conducting validity and reliability analysis for behavioral inhibition questionnaire and concurrent discriminant validity analysis for child behavior checklist and strengths and difficulties questionnaires, collecting the questionnaires that have been approved, filled out, and returned from schools. Our reliability analysis was Cronbach alpha coefficient, and factor analysis was confirmatory factor analysis, and correlations with other scales for concurrent and discriminant validity analysis were made. The age range of children included in the study was 3 to 7, and the mean age was 5 plus 1, and nearly half of the children were boys and other half girls. Mostly questionnaires were filled by mothers, only 20% by fathers, and 2% by other caregivers. Preschool separation subscale scores were found to be statistically significantly higher in boys compared to girls. As marginally accepted due to p-value, physical challenging activity subscale found to be higher in girls as compared to boys. No statistically significant difference was found in the comparison of all subscales and total score according to the person who filled out it, mother or father. And sperm correlation coefficient, behavioral inhibition questionnaire, adult subscale, unfamiliar situation subscale, situational novelty main subscale, social novelty main subscale, and scale total scores revealed a statistically significant but weak positive correlation between age. When it comes to reliability, internal consistency of the BIQ Turkish version was determined by the examination of Cronbach alpha coefficients, item total correlation values, and alpha if item deleted values. The Cronbach alpha value of the total BIQ was 0.92. Cronbach alpha coefficients for social novelty 0.87 and situational novelty 086, which were created as main subscales in the original form of the scale, were found to be highly reliable, like the total scale. In terms of the Cronbach alpha coefficients of the subscales, except for performance and physical challenge subscales, a high degree of reliability was found, also similar to the total reliability of the BIQ. In the correlation analysis, the item total test correlation coefficients were found to be higher than the cutoff points in all items, and the correlation coefficient of the majority of the items was found to be higher than 150. All of alpha item related values were higher than 180, so mostly reliable. And validity, in order to determine the construct validity of the BIQ Turkish form, confirmatory factor analyses were performed, and the correlations of the subscales were checked with each other. And the correlations with the child behavior checklist, shyness, and strength and difficulties questionnaires internalizing subscales were examined for concurrence validity. For the discriminant validity determination, correlations were made with the child behavior checklist impulsivity, smiling, and strength and difficulties questionnaires prosocial behavior subscales. No negative correlation was found between any of the subscales of the scale, while the highest correlations with total BIQ were found between male scales, social novelty and situational novelty, and also peers and unfamiliar situations from subscales showed a very high correlation similarly. And this is the item level internal consistency values for the Turkish BIQ. Mostly high, and also it continues, but it comes to physical challenge. There is some difference from original form because our population difficultly could understand the response to physical challenge. Maybe it comes from there. And convergent and discriminant validity correlation analysis with child behavior questionnaire and strength and difficulties questionnaire subscales. And confirmatory factor analysis and fit index models. A confirmatory factor analysis was carried out to test the fit of the hypothesis previous model of the BIQ as described for the original validation study. The same procedures and 4 models were examined. A single factor model, 3 correlated factors model, 6 correlated factors model, and 6 correlated factors loading onto 1 higher order factor, model 4, as well as 6 correlated factors loading onto 2 main subfactors. And by these 2 factors, items that go to 1 main factor model, model 5, were also examined peculiar to our study. It was added by us. Since the Cronbach alpha value of the physical challenge subscale was far below the acceptable level, this subscale was removed, but since the factor loadings of the 2 items of this scale, only 2 items were above 0.3, the remaining items 13 and 29 in the scale were continued to be used in the main scale. And these are the model fit indices from confirmatory factor analysis for the Turkish BIQ. When we think the previous studies, firstly, this is the original study, scale development study. This was the validity reliability of parent-teacher forms in the Australian population, 3 to 5-year-old children, 613 mothers, 585 teachers, total Cronbach alpha 095 with all subscales except for the physical subscale was 080 above. Validity of the scale with a converging 6-factor structure in the total score was determined. Second, a study from Dutch community, the validity and reliability of BIQ parent form also performed. Children and adolescents in the age range of 4, 7, 8, 11, and 20, 15 years old. A total of 531 caregivers. Cronbach alphas for the total score in the 4-7 age group is 0.96 and 0.95 for other age groups. Validity of the converging 6-factor structure in the total score of the scale. Also, this was 6-factor in the confirmatory factor analysis. Third, the validity and reliability of the BIQ parent and teacher forms in the American population. 495 children aged 3 to 5 years. The total alpha value is 0.95. Good convergent and discriminant validity were identified through correlations with child behavior checklist scales and the laptop observational methods. And fourth, the validity and reliability of the abbreviated 14-item version of the behavioral inhibition questionnaire in the Dutch community and in a multinational sample. And the number was also very high, and children aged 2 to 6 years. The BIQ total alpha coefficient for parents is 0.92, for teachers 0.95, and good convergent and discriminant values were identified through correlations with the preschool anxiety scale and strength and difficulties questionnaire. Confirmatory factor analysis evaluation of BIQ Turkish among various models, the one with a single main factor comprising 6 subscales that demonstrated the highest fits according to other studies, supported only this single model, remaining relatively acceptable in the total scale with 6 non-convergent subscales, 3 subscales, social novelties, situational novelties, and physical challenges, and single models. The model with a single main factor, which is our alternative model, 5 factors go to higher 2 factors, and finally 1 highest factor is supported by increasing fit index values. In this model, items 6 and 21 were removed from the performance scale, and items 4 and 17 were removed from the subscale of physical activities challenges, recurring physical challenges. Therefore, these items were not included in BIQ Turkish, since the Cronbach-Alpha coefficient for the physical challenges subscale was determined to be 0.19. None of the factor models including this subscale were supported in our study, differently from previous studies. In our study, it has been demonstrated that not only the internal consistency of the total scale, but also the majority of the subscales are highly reliable, with an alpha value range from 81 to 87. Only the performance has been found to be quite reliable, and the physical is considered not reliable. An alternative factor structure revealed in our study involves the aggregation of the other 5 subscales, excluding the physical subscale, into the main factors of social and situational novelties contributing to the total scale score. Is this a culture-specific expression of the BIQ? Maybe. Limitations, the lack of assessment of test-retest validity in our study. Due to absence of an alternative scale translated into Turkish to measure behavioral inhibition, convergent validity analyses were conducted using a subscale of a more general temperament scale and internalizing subscale of strength and difficulties questionnaire. Due to the lack of any observational method assessing the Turkish translated and standardized behavioral inhibition, the extent to which reports may contain bias or not has been tested. The limitation of the age range to the preschool period, not older children. The limited number of studies on the validity and reliability of BIQ, with the addition of new findings, including the Turkish population for the first time, was our strongest factor in our study. Simultaneous provision of both convergent and discriminant validity data, demonstrating an alternative factorial validity specific to the Turkish population. Clinical implication, substantial evidence indicate that there is a relationship between behavioral inhibition as a temperamental trait in early childhood and internalizing psychopathologies later. This process can be prevented if the behavioral inhibition is identified appropriately in early childhood. There is a need for an assessment tool that examines behavioral inhibition in Turkish children, because there are only assessment tools look into the temperament as a main concept in general, not as particularly in behavioral inhibition, temperamental trait in Turkey. Turkish version of the behavioral inhibition questionnaire perform is a reliable and valid measure for evaluating behavioral inhibition in 3 to 7 age children. In our country, it's hoped that the groundwork has been laid for future studies related to behavioral inhibition, enabling the easy and reliable screening of these foundational temperamental traits during the preschool period. This is seen as the first step towards developing preventive interventions to reduce the risk of psychopathology in later stages. Thanks for your attention and participation. Is there any question?
So I have nothing to declare, and here are my outline. So let's start with the periodic EEG pattern, which are frequently seen in the intensive care unit, with associated with non-convulsive status epilepticus. So Well known are the lateral periodic discharges, LPD, then generalized periodic discharge, GPD, the bilateral independent periodic discharge, BIPD, the circuits, which are stimulus-induced rhythmic periodic or ictal discharge, and the other periodic rhythmic pattern, not less important than the previous one, like generalized rhythmic delta activity, GRDA, or lateralized rhythmic delta activity, LRDA, and other brief potential ictal-rhythmic discharge, or burn. So here I will start with the lateralized periodic discharge, LPD. This EEG clearly show on the left side, the periodic discharge, periodic and rhythmic discharge occurring all over the exclusively over the left hemisphere, not the right hemisphere. Here are also other lateralized periodic discharge in a 64-year-old male with acute left MCA infarction and some twitching on the right side. What about LPD characteristics? LPD, lateralized periodic discharge, are stereotyped repetitive discharge, recur periodically at regular intervals from 0.5 to 3 Hz. They are broadly lateralized over one hemisphere, usually epileptiform in appearance, and as associated with additional EEG evidence of ipsilateral cerebral dysfunction. They are associated with increased risk of seizure, and this is very important. The clinical significance and the management of LPD is controversial. We will talk about that, and especially in comatose patients. Are LPD unstable, potential epileptiform state, or pattern, or on the common, on the ictal interictal continuum? We don't know yet, but I will talk about this. The epidemiology of LPD, the frequency on continuous EEG monitoring record the LPD the 6.2% to 8.6%. And all found the LPD in 47% of patients in the intensive care unit. LPD are most commonly seen in patients with focal neurological deficit that are associated with varying degree of altered consciousness. Their etiology is multiple, like ischemic stroke, encephalitis, intracerebral hemorrhage, multiple sclerosis, press, migraine, and most commonly, they are commonly associated with cortical gray matter or subcortical gray matter as well. And no structural, no brain abnormality is found in up to 33%. The significance are LPD transient EEG phenomenon following acute neurologic insult, and they might resolve usually within days to weeks, or are they a chronic phenomenon associated with epilepsy? In fact, LPD are found in 5 to 30% of patients with history of epilepsy, and in patients with remote brain injury and epilepsy, 26%, and also in patients with structural lesion and symptomatic epilepsy. What about the LPD and seizure? The risk of the developing subsequent seizure is 10 to 56% in patients with LPD. LPD are highly associated with non-convulsive seizure, according to study of 2004 by Claessens and al. Frequently, LPD are correlated with the seizure risk. The frequency is very important. LPD of less than 1 Hz 1 per second, just 40%, which is high, of seizure. If the LPD reach 2 or more, or beyond 2 hertz, 2 per second or greater, 60% of seizure in patient, in ICU patient. Here are an LPD in a patient with hemorrhagic stroke on the left side. This is so the LPD on the left side, rhythmic, and you can see that this LPD extend to progress toward seizure, which is secondarily generalized. So they are not benign phenomena. The prognosis LPD are associated with high mortality rate, and they are independent predictor of poor outcome according to classes as well. There are other LPD called LPD plus, which is prolonged after discharge. They have an ictal appearing associated with fast activity or some rhythmic activity, delta in general data, or both. This feature, this LPD plus, are highly associated with clinical seizure. Here are this LPD plus. You can see that there are some LPD plus after discharge, and they are, of course, mixed with fast frequency, as you can see them here. Or there are LPD here on the right side. These LPD are on the right side, and you can see they are associated with delta, small delta activity, low voltage delta activity, as can you see there. Also, the frequency, the change in frequency are highly epileptiform. Here, these LPD are evolving from small amplitude to higher amplitude, and to change in frequency. Are LPD an ictal pattern? They are when associated with the clinical correlate, like focal chronic seizure, contralateral to LPD, of course, or epilepsia partialis continua. LPD, when associated also with certain clinical manifestation like a deviation, aphasia, hemianopia, they can be, of course, an ictal pattern. Also, in patients with altered mental status, LPD may be ictal. In this patient, the EEG show clearly some lateralized periodic discharges in a 50-year-old man admitted to the ICU with altered mental status, confusion. After an injection of 4 milligram IV of lorazepam, a benzodiazepine, anti-seizure medication, you can see that there is a big improvement in the EEG and in the level of consciousness. So the patient was obviously suffering from a non-convulsive status epilepticus. What about the management of patients with LD? There are no data about this. However, neuroimaging should be performed in all patients with LPD to look for cortical or subcortical lesion. A metabolic reversible condition should be treated if possible, and easy monitoring of more than 24 hours is recommended in this case, and most patients with LPD should be treated if accompanied by, of course, abnormal movement or other central phenomenon, or if their frequency and their amplitude or morphology change. Should we continue anti-seizure medication after hospitalization? There are no data about this. I will talk now about generalized periodic discharge. As you can see, this EEG show generalized involving both hemispheres at 1 per second, sharp wave-like occurring at 1 per second, and predominantly anterior, involving the frontal and the central leads. Here are another generalized periodic discharge in a 65-year-old man with hypoxic ischemic brain injury after cardiac arrest. Most of these generalized periodic discharge are seen in patients with hypoxic ischemic brain injury after cardiac arrest. But we can see them in other lesion of the brain, like traumatic brain injury and encephalitis, etc. The GDP, the characteristics are symmetrical, bihemispheric, repetitive discharge with a regular morphology. They are frontal or they have frontal or occipital predominance, and the majority of patients with GPD are comatose, which is not the case of lateralized periodic discharge. And at the initiation of the EEG, the continuous EEG monitoring, they are mostly comatose. The generalized periodic discharge occur with all this pathology, as you can see. And what about the relation to seizure? The GPD are associated with seizure, and mostly and predominantly with non-convulsive seizure in 27% of patients with GPD, and with non-convulsive status epilepticus in 22% of patients with generalized periodic discharge. GPD with the plus feature like fast activity or small delta activity, rhythmic delta activity, and the sharper morphology or increased frequency, increase the possibility of seizure on the EEG. And GPD, of course, may reflect an ictal rhythm. This slide clearly shows on the middle row, look at this one, the patients with GPD are represented here in green, and in green bar, and the patient, the control, are represented in gray here. You can see that the most of the patient with GPD suffer from non-convulsive seizure, also convulsive seizure, but mostly non-convulsive seizure, non-convulsive status epilepticus, and also convulsive status epilepticus. So, in summary, the GPD are strongly associated with non-convulsive seizure and non-convulsive status epilepticus. The GPD, this EEG, represent generalized periodic discharge at 1 per second, predominantly frontal, and associated with fast activity. We call that GPD plus F. What about these are GPD, but they have a triphasic morphology. This is one phase, the second phase, and third phase. This is triphasic morphology. Unfortunately, triphasic morphology, GPD are not only seen in hepatic encephalopathy, but they can be seen also in in non-convulsive status epilepticus. The GPD with triphasic morphology is associated also with metabolic encephalopathy, but there are also a rare pattern in non-convulsive status epilepticus. And the improvement of both EEG and the clinical with benzodiazepine, such as lorazepam or Valium, diazepam, is consistent with non-convulsive status epilepticus. The benzodiazepine abolish the triphasic wave with triphasic morphology, of course. Without clinical improvement, we call that non-convulsive status epilepticus a possible one. Patient with triphasic wave likely to develop seizure compared to those without. Hello? Hi. This is a generalized periodic discharge with triphasic morphology, with a change in amplitude of the wave. They are bigger here now, and the frequency also. So after in a patient with altered, of course, a comatose patient, after lorazepam 4 milligram, you can see that there is a spectacular improvement in the EEG, but no clinical improvement, which means that the patient is in coma and is probably a possible non-convulsive status epilepticus in coma. What about GPD and the prognosis of the patient with GDP? The mortality of patients with GDP is high, 34 to 47%. They are predictor of poor outcome in patients with coma, sepsis, anoxic encephalopathy, and the development of non-convulsive status epilepticus. Few patients with anoxic encephalopathy and GPD regain consciousness. What about another type of periodic discharge? Is generalized rhythmic delta activity. This feature in the EEG are seen mostly in hepatic in encephalopathy, either metabolic or also infectious. They are related also to seizure, but to a lesser degree, maybe 5 to 10%. Not to confuse this generalized rhythmic delta activity continuous with this one, which is generalized rhythmic delta activity or limited and just for a short period over the frontal leads. It's called FIRDA, or frontal intermittent rhythmic delta activity. This has no relation with seizure, and it's associated with white matter lesion of the brain or middle lesion. Another feature of rhythmic discharge is what we call bilateral independent periodic discharge. These are, as the GPD, are highly associated with non-convulsive seizure and non-convulsive status epilepticus. This discharge here, the black arrow show that the discharge are arising from the left side of the brain, here also, C7, P1, and the right arrow show that the other discharge, not synchronous with this one, asynchronous, are arising from the right hemisphere. That's why we call them bilateral independent periodic discharge. Another feature or rhythmic activity in this patient, 60-year-old male with altered mental status with no abnormal movement, is what we call lateral rhythmic delta activity. As you can see, this is the left side and this is the right one on the right, or red, yeah, in red. I mean, this is what we call delta activity at 4 per second, 1, 2, 3, 4, and it's running only over the right temporal and little bit the frontal also area. This one are lateralized delta activity and highly epileptogenic as well. The last feature, the last rhythmic periodic and rhythmic activity are what is called SIRPID or stimuli-induced rhythmic periodic or ictal discharge. This feature are seen in patients with altered mental status or comatose with when you rub the sternum, you rub the sternum or the jaw, you can see some discharge which are quite rhythmic, epileptiform in appearance, and might induce some jerky movement. We don't know much about this SIRPID. They have been reported recently over the 5 to 10 years. We cannot talk about the periodic discharge without talking about the continuous EEG monitoring. Continuous EEG monitoring for hours or days is actually running all over the hospital in ICU. Is proven to be very useful in the assessment of patients with disturbance of consciousness in various clinical fields. Of course, the continuous EEG is greater than the emerging EEG recording for 45 minutes or 1 hour. The non-convulsive seizures are common in encephalopathic patients, even in the absence of acute brain injury, and can only be observed using the EEG monitor. One word about what we call the ictal and the ictal continuum. It has no excellent and good definition, but roughly it is a pathophysiological dynamic state in which unstable neurobiological process and the coexistence of acute metabolic disturbance, all those features contribute or not to the appearance of convulsive or non-convulsive seizure or status epilepticus. The ictal and interictal continuum include the non-periodic rhythm that I reported above, LPD, lateral periodic discharge, general periodic discharge, bilateral independent periodic discharge, lateral rhythmic delta activity, and generalized rhythmic delta activity. And also it comprises periodic rhythmic with a frequency of 1 to 2.5 without spatiotemporal evolution and without clinical manifestation. So in summary, the ictal and the ictal continuum is represented by interictal when they manifest a frequency of less than 1 Hz, so they will not induce any seizure, or they can be non-convulsive seizure and non-convulsive status epilepticus when they present a frequency of more than 2.5 Hz per second and show a spatio-temporal evolution, means that change in morphology, change in amplitude, and change in frequency, and also dissemination to the other hemisphere. Ictal and interictal continuum include also rhythmic periodic pattern with a frequency of 1 to 2.5 Hz without a spatial temporal evolution and without clinical correlation. How to treat that is still an enigma. However, if in case of any abnormal feature like a movement, some subtle myoclonic jerk, or abnormal discharges with change in frequency amplitude, trial of benzodiazepine is worth it. This slide clearly represents what they call the ictal interictal continuum. So all these are there. The lateral periodic discharge are there, generalized periodic discharge, bilateral independent, lateralized rhythmic, and CRP are all there. If their frequency is in between 1 and 2 Hz, so they are just interictal. If their frequency increase beyond 3 Hz or 2.5 and 3 Hz, they become ictal and may evolve into generalized chronic status epilepticus or non-convulsive status epilepticus or non-convulsive seizure. The risk of electrographic seizure associated with ictal interictal continuum, it's increased morphology, duration, and frequency of ICU pattern, highly predictive of the risk for seizure. The incidence of seizure in critically ill patient is up to 95 in patients with LPD, up to almost 80% of patients with biplets, bilateral independent periodic discharge, almost 90% in patients with GPD, highly epileptiform, and up to 63% in patients with lateralized rhythmic delta activity, but less in generalized rhythmic delta activity. Of course, there are higher risk when you have LPD plus rhythmic discharge delta activity or LPD plus fast activity. What is the risk of epilepsy in patients with ictal interictal continuum pattern? Overall, 10 to 60% of patients with LPD develop chronic epilepsy after discharge from the hospital. Patients with the LPD have a relative risk of 7.7 of developing epilepsy compared to those without. The presence of lateral periodic discharge and other inacute traumatic brain injury is strongly associated with post-traumatic epilepsy, as also is associated in ischemic stroke with an EEG showing lateral periodic discharge. So the message to take home is the first step. If we have to differentiate the pattern found in the ictal interictal continuum from the pattern of rhythmic activity less than 1 Hertz, from seizure and non-competitive status epilepticus, which is with a frequency of more than 2.5 to 3 Hertz, and the change in morphology and frequency, of course. The widely adopted Salzburg and the American Clinical Neurophysiology Society criteria are used to extract non-convulsive seizure and non-convulsive status epilepticus from the ictal interictal continuum, identify them and treat them. A brief one word about the Salzburg consensus criteria for non-convulsive status epilepticus. Here are the rhythmic activity we have spoken about, the lateral periodic discharge, generalized, etc. This more than 0.5 Hertz with the fluctuation, evolving rhythmic activity, and the rhythmic activity more than 0.5 Hertz without fluctuation also can induce or can evolve to non-convulsive seizure or non-convulsive status epilepticus. Thank you very much.
Interested in studying about autism, and I would like to inform people about the topic. So today's topic will be looking at autism spectrum disorder. At first, they will try to interact with the surroundings. The next 5 to 6 months, the child will follow their parents' footsteps. At the age of 3, they build up their characters. Autism depicted as early as 12 months old. Okay. Then here are the definitions of autism. The first one is developmental disorder, which means learning difficulties and trouble in speaking with other person. Then we have post-traumatic disorder, which refer to stressful events and distressful emotions. And then we have abnormal responses, which are unaware of their reactions and behaviors. And then we have neurodevelopmental disorder, which include language fluency and body movement. In 1938, autistic psychopathy was pronounced by Hans Asperger, emphasized the sociability skills such as lack of eye contact, cannot contain information, and avoiding people. In 1980, autism, given under the Diagnostic and Statistical Manual of Mental Disorders, which signifies social skills, repetitive behaviors, and nonverbal communication. Then we have autistic disorder under the recognition of American Psychological Association in 2000, pertaining to physical and mental abilities. Autism is under the pervasive developmental disorders, which shows delays in social and communication skills. Autism spectrum disorder is a modified word for a wide range of autism-like disorders. Okay, here are the signs and symptoms of autism. The first one is on psychiatric conditions, which are obsessive-compulsive disorder, will become an obsession, causing repetitive behaviors such as cleaning, hand washing, checking doors are locked, and repeating words in the head. And then we have stimming, which is self-stimulating behavior, such as arm or hand clapping, spinning or twirling, and finger flicking. And then we have anxiety disorder, which is the feeling of restless and trouble concentrating. Then we have unstructured play, in which there is no intervention from adults, such as drawing, painting, and inventing games. Okay, then we have medical conditions. The first one is self-harm, and then we have allergies, which are sensitivity towards environmental pollutants. We also have gastrointestinal inflammatory process. That is when the stomach lining is red and swollen due to allergic and immune intolerance. Then we have constipation, diarrhea, and also recurrent bacterial infections, which are skin infections, including ear infection and sinusitis. Here are the complications of autism, which are headaches, visual disturbances, that is visual problems, dental issues, frequent infections, that is immune deficiency, there is lack of immune response due to insufficient numbers of antibodies. And then we have immune system dysfunction, which are improper function of the immune system, such as pollen allergy due to genetic disorders. Then we have sleep disturbances, also gastrointestinal diseases, for instance, food poisoning and lactose intolerance. Then we have neurological conditions, which are conditions that affect the brain and nervous system, such as Alzheimer, dementias, migraines, and head injuries. Dermatological problems include skin disorders, including acne and itchiness of the skin. Here are the risk factors of autism. The first one is advanced parental age, and it's shown that fathers have such a strong genetic influence on autism. Then we have genetics, since autism are highly heritable by mutation process which changes the DNA sequence. Then we have gender differences, which did not pay much attention to autism since it occurs during the birth. Socioeconomic status, since it does affect their physical and mental health in terms of family income, education, and psychological status. Okay, here we have therapeutic strategies for autism. The first one is dietary planning. They have their own favorite food, but they dislike the others, even if it is highly nutritious. And then we have behavioral therapy. They have to ensure that they stay positive and have the right kind of attitude when facing challenges in life. And then we have squeeze machine that act as a calming effect and having a feeling of comfort like being hugged. And then lastly, artificial intelligence and machine learning also play a role in reading behaviors and emotions of the child to make them more expressive of their feelings. In conclusion, autism is a neurodevelopmental disorder. There is no cause have been identified for autism. There is still hope of having a more sophisticated approach to autism. That is all from me. Thank you.
Thank you so much, Dr. Noor. That was an excellent presentation. Would anyone like to ask a question?
Disease and dementia with Lewy body. So few things on outlines. First, biological background, infrared spectroscopy, methodology, results, and conclusions. So a few things or few points on Alzheimer's disease. What is actually Alzheimer's disease? Is a significant deterioration in the mental ability to deal with normal daily life. This is called dementia in general. Alzheimer's disease accounts for 60 to 80% of all dementia. Dementia with Lewy bodies, this is another type of dementia, is thought to be the second common disease and accounting for 20% of all cases. So AD and DLB are diseases related to aging. So therefore, as life expectancy is increasing, we expect to be a major ailment that lead to death and impose heavy financial burden. Now, why it's important to diagnose Alzheimer and DLB as quickly as possible. Early symptoms of both AD and DLB include difficulty remembering names, recent events, and so forth. DLB, on the other hand, develop as a symptom such as blank expression, delusion, sleep disorder, decreasing alertness, recurrent visual hallucination, fainting, fluctuations in autonomic process, and repeated falls. So what are the reasons for these diseases, AD and DLB? The exact cause of Alzheimer and DLB are not fully understood so far. Probable causes of AD is due to formation of senile plaques and hyperphosphorylated tau protein in neurofibrillary tangles and mitochondrial dysfunction and environmental toxins. Now, how Alzheimer is currently diagnosed. So I will show you a few points. First of all, there is no single clinical method available to diagnose AD. There are no motor, sensory, or coordination deficit early in the disease. So the diagnosis cannot be determined by validating clinical tests. That's the problem. Now, the common methods to diagnose Alzheimer's disease and DLB is, first of all, mini-mental state examination, which is a simple test the doctors do. Then positron emission tomography, which is called PET, magnetic resonance imaging, MRI, computerized tomography, electroencephalogram, EEG, and cerebrospinal fluid technique. Now, more recent techniques have been developed, and this is what I want to mention. New techniques were developed, like single photon emission computed tomography, SPECT, which is advanced method, and fluorodeoxyglucose, PET. It's called FDG PET, which is a fluorodeoxyglucose PET. Several cerebrospinal fluid biomarker like tau phosphorylated and tau amino acid from amyloid beta have been developed. And also different spectral methods were used to analyze CSF. Now, why it is important to diagnose Alzheimer and other dementias very early? So even though the underlying AD and DLB processes cannot be stopped or reversed, early and accurate diagnosis is beneficial for several reasons. First of all, early diagnosis and treatment may help preserve the daily functioning for some time. Second point, the available treatment can improve the quality of patient life by slowing down and slowing the worsening of dementia symptoms. So now I will go to our method. Our method is infrared spectroscopy, to use infrared spectroscopy to diagnose Alzheimer. First of all, you can see here the entire electromagnetic spectrum, starting from gamma rays, which are the shortest waves, then going to X-rays, UV, infrared, microwave, and radio wave. Actually, I want to tell you that all the regions are used in medicine. Everything is used in medicine, but we focused on the infrared region, and more particularly mid-infrared region. It's called MIR. MIR is middle infrared region. And I'll tell you in a minute why it's important. Now, if you take a molecule, general molecule, you have electronic excitations. This is called electronic excitation, where the electron is excited to a higher state. On top of these, there are vibrational states due to vibration of the molecule. And on top of the vibration, there is rotational spectrum. So things are very complex. So the vibration are sitting on the electronic and the rotational on the vibration. What we measure in infrared spectrum is the vibrational excitations. Actually, vibrational spectrum. Now, I'll show you how it looks like. For example, take the simplest molecule, which is water, H2O. And you can see the vibrations of the molecule when infrared light hits the molecule. You can see the symmetric stretch. This is the hydrogen and the oxygen, and you can see the symmetric stretch. There is an asymmetric stretch like this, and there is a bending stretch. Bending vibration. It's like this. Every vibration has its own energy. So one can tell which is which just from the energy. There is a rule called 3n minus 6, which is the number of degrees of freedom. N is number of atoms. So in this case, 3 times 3 is 9 minus 6 is 3. We have 3 degrees of freedom. Just this. For the linear molecule like CO2, carbon dioxide, we have 3n minus 5. So we have a symmetric stretch, we have asymmetric stretch, and we have 2 bending. Now, I will not go into detail, but the symmetric stretch, we cannot see it in infrared because the dipole moment is 0. So we see 3, we see the asymmetric, asymmetric and the bending. Now, how it looks like for a complex molecule like a protein, which has a lot of atoms. So you can see here a typical protein, how it vibrates when infrared light hits the molecule. So for example, you can see here on the left, you can see that the 2 main peaks or main vibrations are amide2 and amide1. Amide2 is the CN stretching, this CN stretching of the molecule, and amide1 is the C double bond O, C and O. Now, how we measure this? So the measurement is done with infrared microscope. And the main part in the microscope is the Michelson interferometer, which is this. I'll show you how it works. Actually, you have like something like this, a fixed mirror here and a moving mirror here. So the light from the lamp, from the global lamp, is hitting a slide here, which is I would say, yes, a reflecting slide. Half of the light is reflected and half is transmitted. but this mirror is moving. So the two lights are coming up together and hit our target. This is called Michelson interferometer, and this is a very important unit in the microscope. And you can see here a typical spectrum of white blood cell. Just take white blood cell, the spectrum is like this. So we can see all components, lipids, the protein, lipids are the blue, so these are lipids. We can see the proteins contribution, nucleic acid contribution, and the carbohydrate contribution. So actually, the spectrum is a typical fingerprint of the sample. So in conclusion of this part, mid-infrared absorption spectrum, which are considered as biochemical fingerprint of the sample, enable both qualitative and quantitative analysis of the measured biological samples. Infrared spectroscopy with machine learning has become a rapid and cheap and objective diagnostic tool. Many studies have reported the use of FTIR of biofluids for rapid and objective and accurate diagnosis of disease at early stages. So we thought this method will be very useful for Alzheimer's disease. And I will show you in a minute. What we take a very few milliliters of blood from the patient. We separate it by centrifuging, and we have the layer of RBC, of histopac, which is the liquid we add. WBC, white blood cell, is the layer here, and plasma. And in fact, we measure two things. We measure the WBC, and the plasma. WBC, one layer, and plasma. So we have two measurements of each. From the blood, we prepare the samples like this, many samples. And we use the sample in the infrared microscope, which is here, like this. It looks like this. And we put the sample here, and we can measure the spectrum of the sample, of the white blood cells or plasma. And we first get an interferogram. This one is called interferogram, which is the intensity, signal intensity, as a function of optical path length. From this, we do transform Fourier, or Fourier transform of the spectrum here, and we get the absorption spectrum, which is this. So here we can see where the light is absorbed in the WBC and in the plasma. From the absorption spectrum, we get, from the transmission, we get absorption spectrum like this, and we do some adjustment, and we get the final spectrum. So here you can see the final spectrum, actually of 16 samples from the single patient, from one patient. You can see that the spectrum is very reproducible. It's very accurate. All the 16 fall almost on the same line. So we do like this. We test every sample like this. So the number of patients we have controls, for example, for WBC. We have 26 controls, and we collected 145 spectra. And for the dementia, AD, and DLB, we have 30 patients, and we collected 180 spectra. And similar for the plasma. Here you can see the final spectrum of all of AD, Alzheimer, DLB, and control. And you can see that the spectrum is actually very similar. there is a slight deviation, and this is what we are looking for, the deviation between AD and DLB and controls. The highlight region here is the standard deviation of the spectrum, of all the spectra. So just notice that the spectra are similar. That's why we need machine learning methods to separate between the groups. And here, this is called the second derivative of the average spectra. You can see again, the blue is the AD, red is the DLB, and green is the controls. You can see the differences are not large, and we need a sophisticated method to differentiate. This is again for the plasma. Before it was for the WBC, now this is the plasma. Summarize this. The spectral differences between the categories are minute. Therefore, we need to apply algorithms to separate them. We use two algorithms, support vector machine, which is called SVM, and random forest classifier. I'll show you both. We first considered a binary classification, which means we took the control against all dementia. Dementia we called AD and DLB together, one group. We call it dementia. And we tried to separate between control and dementia. Then we used the leave one out cross-validation to get the estimate of the performance. And then we used the AUC, which is called area under the curve, to represent the quality of the classification. I will show you in a minute. This is called ROC curve. This is receiver operation characteristic curve, which is used in medicine. When you see a curve like this, if the area is one, it's a perfect. One is going like this, going up and flat. So here, it's not perfect, of course. We get an area under the curve of 0.9 for the WBC, which is the area under these curves. The blue is the one classifier, random forest, and the other color is the SVM, the supervised vector machine. And here we can see the results for the plasma. It's very similar, but for the plasma, we get slightly less accuracy. You see the area under curve in the WBC is 0.9, and here is 0.83. So WBC, the white blood cells, are preferred for analysis than the plasma. Here we can see the summary of the results, and we can just focus on the accuracy. So using the random forest, we get accuracy of 0.86, 86% accuracy to diagnose Alzheimer and dementia, both. And for the plasma, it's slightly less, is 0.81. And here is again the ROC curve for WBC and plasma, but now we aimed to distinguish between AD and DLB, between the two dementia processes, AD and DLB, sorry. So here you can see that we can categorize between AD and DLB with accuracy of 88%. And for the plasma, 84%, is slightly less. And here we see the performance of the best classifier between AD and DLB categories. You can see the WBC here, first line, and plasma here, one using the SVM classifier, the other one is RF random forest classifier. So we get accuracy of 93% for using the WBC and 81% using the plasma. In summary of the method, when we have a new patient, we get a few milliliters of blood. We separate the blood and measure the FTIR. We can tell with accuracy of 86%. We can differentiate between control and dementia. And then if we take the dementia and we subgroup, we can differentiate between AD and DLB with 93%. So in conclusion, FTIR microscopy of simple blood test in tandem together with machine learning algorithms make it possible to differentiate between dementia, which is altogether AD and DLB, and controls. And we can separate between AD and DLB patients with good accuracy. With a promising success rate and with a time span of 70 minutes. This is the time it takes for the process. It's mainly to separate the blood, actually. This is the main thing. The analysis based on WBC, infrared absorption spectra, enable the classifiers to achieve higher success rate in all the classification experiments. So here I mentioned that the WBC is superior than the plasma. Increasing the database in the future will significantly improve the classification results, and therefore a larger collaboration is desired. Actually, we can improve the method, but we need a lot of patients. That's the problem. And this takes time, of course. Okay, thank you very much. This is the end of the talk.
Thank you. That was a wonderful presentation. Does anyone have any questions to ask the doctor?
Functionality, quantification, and modeling, first of all. However, before I continue, I would like to thank you to conference headquarter representatives for opportunity to have a presentation at your conference via online space at least, and apologize my co-author and me, we could not participate your conference personally because of our other duties, which we have at our employers. However, I would like to say a few words related to objectives I am interested in as well. My name is Eva Skolvagova and my background is the psychology. I am university teacher acting at University of Žilina, Slovak Republic, Faculty of Humanities, Department of Pedagogical Studies, where I am teaching psychology and providing consulting services for my students and the university employees. Furthermore, I would like to introduce my presentation thesis very briefly. In general, any psychological process is closely related to living organisms and reflects their behavior determined by their internal and external components. In order to predict their behavior, their structure and functionality should be understood, quantified, and modeled. This approach requires providing many different research activities, which generate a huge data and information set concerned with behavior of living organism, which should be transformed to appropriate knowledge and applied related to communication with living organisms. And that is the main goal of my presentation, together with psychological process investigation, their structure and functionality, metrics, information and knowledge-based support, and with their quantification and modeling. Now, let us have a look at those objectives in more details. Introductory information. In general, a mental or psychic process is created by several different partial processes like sensing, perception, creation of imaginations, thing, memory, attention, feelings, regulation of acting, voluntary and extra-voluntary acting, while they determine external behavior of all living organisms and entities. On the other hand, that behavior is closely related to internal and external biological substrates, the living organism or entity consists of, while there is a set of appropriate biological substrate status, which might be observed as the living organism or entity external or internal behavior, which is being interconnected to environment, where the living organism or entity is living in. At present, an investigation of mental processes is closely related and concentrated to their content and form, while that investigation generates a lot of different data sets being processed with the use math statistics regulations and algorithms, which enable determining adequate relations and dependencies. However, the above-mentioned regulations and algorithms have a limited action radius when providing investigations related to behavior of living organisms or entities. 1. However, at present a more complex view related to that behavior is required, where a process view plays a role of significant importance and therefore the term psychological process is being introduced as well. 2. While an investigation subject deals with that process structure, functionality and metrics. 3. Together with process information and knowledge-based support, which plays a role of principal importance there. However, that approach is similar when comparing it with social or business processes as well. 4. While the presented article deals with investigation of psychological process, where a process view and approach plays dominant importance too. The presented article main goal is to define the psychological process, its structure, functionality, and metrics, together with adequate information and knowledge-based support, which enables the PP process to be quantified and modeled, while adequate models create a good basis for design and implementation of an appropriate application program, knowledge-based or expert system, which could enable generating more complex knowledge concerned with investigated psychological process. Psychological process. Psychological process represents a set of steps or mechanisms acting within appropriate sequence, which enable achieving changes related to behavior or emotions of living organisms or entities, and those steps are formulated as a set of organized changes within organism status and its environment. 5. The psychological investigation aims. The aims of psychological process investigation is analysis and evaluation of data generated or consumed by PP processes applied for understanding of principles related to their structure and functionality and transformation to adequate models, while PP process modeling follows 2 aims as well. The PP process structure element quantitative description together with data features, which were gained as a result of PP's investigation, seems to be the first aim. A creation of hypothesis concerned with investigated PPs and data generated by them seems to be the second aim. However, one more aim should be added: the above-mentioned aims, which closely related to PPs, which should create basis for knowledge-based or expert system design and implementation, while those systems should enable the authorized user, the psychologist, to provide generating new, primary knowledge based on data gained as a result of PP's investigation. However, there should be a possibility to generate new knowledge based on existing one extended by new research data as well. 6. The investigation objectives. The psychology research objectives had been changing within periods, and now, the psychology deals with human living and behavior and appropriate mental status and appears. However, there is a question related to acting of those aspects, how they affect a human life, how they are being changed, and what about an influence they have concerned with human living and behavior as well. On the other hand, the above-mentioned research objectives are closely related to collecting, evaluating and interpreting data, which enables the psychological processes quantification and modeling. 2, 7, 8. The psychological processes, structure and functionality. In general, any psychological process is considered to be a core process and is represented by its vertical and horizontal structure, while that structure type is represented by main, subordinated, and elementary processes. 12. On the other hand, the psychological process, PP process, horizontal structure is created by inputs, outputs, and function, which provide conversion of inputs into required outputs, while they might be quantified via linguistic sets when applying linguistic modeling approach. 9, 10. The linguistic set content is concerned with behavior of living organisms or entities, appropriate attributes, which are closely related to manifestations and behavior of living organisms or entities within their internal and external environment. 11. The psychological processes, metrics, support, quantification, and modeling. As mentioned above, any process is represented by its vertical and horizontal structure. However, further category concerned, its functionality and performance is denoted as metrics. There are two types of metrics: A, external metrics, which is closely related to process outputs and inputs, and B, internal metrics, which is concerned with human resources, devices and tools needed from process functionality and performance point of view. 2. When applying that approach to psychological processes, its external metrics is closely related to living organism or entity external attributes. It means attributes which represent the living organism or entity manifestations and behavior within external environment. On the other hand, the PP internal metrics is closely related to living organism or entity internal manifestations or behavior, including relations among them. The PP process external and internal metrics create basis for design and implementation of PP information and knowledge-based support, their quantification and modeling. All the above-mentioned aspects enable providing design and implementation of an appropriate knowledge-based or expert system. However, this system enables to authorized user, psychologist, generating primary knowledge based on his/her research data and the other new knowledge based on existing ones as well. 6. General overview. In general, any process, social or economic, regardless applied investigation and modeling approach, is represented by its own vertical and horizontal structure. On the other hand, no of the above-mentioned process proper and efficient functionality is possible without appropriate information and knowledge-based support. However, the same approach is applied when investigating and modeling the psychological processes. As well, while there are adequate linguistic sets, which enable PP process quantification and modeling, with respect to process linguistic approach modeling. Now, let's have a look at PP horizontal structure modeling. As mentioned above, the PP vertical structure is represented by inputs, outputs, and functions, PPFs, while those components are being quantified and modeled via linguistic sets, the content of which is created by indicators closely related to living organism or entity biological substrates, which determine their internal and external functionality, and the indicators are quantified via adequate attributes and attribute values. The living organism or entity structure components. The living organism or entity components determine their internal and functionality and their external behavior as well, which indicated via component status and which might be quantified via adequate indicators, their attributes and attribute values. On the other hand, the living organism or entity status might be formalized via adaptive functions and their variables, which create an integral part of the above-mentioned indicators. 11. The living organism or entity behavior. The living organism or entity behavior is determined by their internal functionality and external manifestations, while their internal functionality is closely related to biological substrates and adaptive functions, which play a role of principal importance here. The attributes closely related to living organism or entity components. The attributes closely related to living organism or entity component might be quantified via linguistic sets, a content of which is created by adequate attributes and relations among them, while they can be of a stochastic or heuristic features. On the other hand, those attribute features correspond to biological substrates, which create an integral part of living organism or entities. The psychological process vertical structure. In general, any psychological process seems to be the core process from process and procedural point of view, while that process has an appropriate hierarchic structure created by main, subordinated, and elementary processes, while that concept might indicate changes closely related to actual psychological process. The psychological process horizontal structure. General overview. In general, the psychological process horizontal structure is created by input and output and PPF's linguistic sets, while a content of PPF's linguistic sets is created by transformation rules and transformation tools, which provide transformation of inputs to required outputs. This approach will be applied when quantifying and modeling PPs. The living organism or entity components, the biological substrates and their adequate status values represent the PP inputs, and a set of their manifestation and behavior indicators represents the PP outputs. Detailed description. PP inputs. All inputs closely related to PP processes deal with living organisms or entities, low, and might be divided to appropriate categories postulated as follows: A. Living organism or entity components. B. Low, living organism or being component relations. C. Lewy, living organism or being appear relations. D. Love, living organism or entity events. E. Lover, living organism or entity event relations. Each of the above-mentioned categories is being quantified via linguistic set, the content of which is created by adequate attribute and attribute values. PP outputs. The PP outputs deal with living organism or entity external and internal behavior and manifestation indicated by status values, appears, events, while the indicators, their attributes and attribute values create content of adequate linguistic sets. The PPF, which creates a significant elements of PP horizontal structure, might be quantified via adequate linguistic set, which that set contains two significant subsets. The first subset contains data closely related to transformation rules, which regulate acting of transformation tools, while the transformation tool set contains data closely related to living organism or entity internal components, biological substrates, material causes, the biological substrates, functional causes, and functional components, functionality of biological substrates, together with external components represented by adaptive functions. All the above-mentioned components are being quantified via adequate indicators, their attributes and attribute values, and they are of ontological and stochastic nature, and their acting is being reflected. Within reality of a psychological attribute resides in its functional manifestation. The psychological process vertical structure. In general, any psychological process seems to be the core process from process and procedural point of view, while that process has an appropriate hierarchic structure created by main, subordinated, and elementary processes, while that concept might indicate changes closely related to actual psychological process. Psychological processes, quantification and modeling. In general, the psychological process structure and functionality, metrics and information and knowledge-based support components create bases for their quantification and modeling. When considering the user's position who is interested in investigation of psychological processes, he or she would be very glad to have an adequate application program, which could enable him/her generating knowledge based on research result data and subsequently generating new knowledge based on existing one. Therefore, PP model creation play a role of principal importance in order to achieve that aim, while that model is based on linguistic sets and knowledge is represented with use of semantic networks and reference databases. The above-mentioned activities create an integral part of activities provide in the future and will not be discussed within that contribution. The psychological process information support. General overview. In general, the process information support is derived based on the process metrics, and the PPs do not create any exception. Because of the PPs are closely related to living organism or entity behavior and appropriate external and internal manifestations of them are being observed, they have to be respected when designing and implementing the PP models. With respect to those facts, it should be respected their internal and external behavior when creating those models, where adequate linguistic sets are applied, while their content is very different, and they determine PP information support structure in a great deal. Furthermore, the PP process external information support aspects will be discussed in more details. However, the approach applied to internal information support aspects are quite similar as well. The psychological process information support, derived based on living organism external manifestation aspects, conceptual model. The living organism or entity external aspects being quantified via indicators, their attributes and attribute values stored in P6, I, J1, linguistic set represent an input set related to PPPL equation, which enable quantifying the above-mentioned psychological processes. On the other hand, the Pxt, I, J1, linguistic set seems to be the second one, which creates the PPA equation left side and consists of two subsets denoted as rulesext, I, J21, A, toolsext, I, J22, while formula might be postulated, where the rulesext, I, J21, linguistic subset content is created by set of rules which regulate transformation of indicators contained within peak-6th IJ1. On the other hand, the tool-6th IJ22 linguistic subset content is created by transformation tools which provide of conversion of data contained within peak-6th IJ1 set into required outputs contained within the peak-6th IJ3 linguistic set, while there might be adequate application software or hardware components. The peak-6th IJ3 linguistic set together with peak-6th IJ4 linguistic set, the content of which is created by indicator closely related to relations among the peak-6th IJ3 set elements, represent the PBPL equation right side. However, the general PBPL equation, see also Formula 3.1 vertical bar form, might be transformed to the form postulated via Formula 4.2 as well, while peak-6th IJ3 linguistic set content is created by indicators closely related to external behavior of living organisms or entities. The peak-6th IJ4 content is created by indicators closely related to relations among peak-6th IJ3 elements. However, the similar consideration might be applied related to PP information support internal aspects as well. The psychological process information support, derived based on living organism external manifestation aspects, logical model. The PP information support logical model is being derived based on the conceptual one and represent linguistic sets content, which create an integral part of PBPL equation left and right side. The psychological process information support, derived based on living organism external manifestation aspects, implementation model. The PP process information support will be implemented via graphic databases, ontotext system, where the above-mentioned linguistic sets will be represented via adequate RDF files. 14. Those files will be applied for implementation of so-called main reference database with 4 subordinated reference databases implemented with the use of RDF files, while each of RDF file corresponds to one linguistic set and its content. Psychological processes, knowledge-based support. General overview. In general, the PP process knowledge-based support is provided via appropriate knowledge-based or expert system, which consist of 2 subsystems, A. Knowledge base, KB, and B. Inference engine, EA. The knowledge structure contained within knowledge bases is derived from knowledge representation system. In that article, the knowledge representation system is based on semantic networks and reference databases, which enable linguistic sets implementation, while those sets enable providing knowledge representation and PP process quantification via PBPL equation. The PEAT-I-J linguistic set. The linguistic set content linguistic set is being created via indicators closely related to living organism or entity biological substrates, which create an integral part of PP processes, hereinafter known as PP biological substrate indicators, while they create content of subset. However, the above-mentioned substrates indicate appropriate status indicators, PP biological substrate input indicator status, which create an integral part of subset, while both the subsets create an integral part of linguistic set as well, and that set creates basis of RD1 SINT partial reference database. The TPEX-I-J linguistic set. The internal biological substrates and their status variables are closely related to PP process structure and functionality, which indicate adequate dynamicity which deals with living organism or entity external manifestations and behavior, while the indicators applied for their quantification are contained within linguistic set. This set consists of 2 subsets, the content of which enables quantifying results related to living organism or entity manifestations or behavior and seem to be output elements, and the linguistic set is denoted as the output set. While the subset contains elements closely related to PP biological substrate output indicators, and the subset represents elements closely related to PP biological substrate output indicator status. Both of the above-mentioned subsets represent the SNW1 SINT partial semantic network. The PEAT-I-J linguistic set. When considering a fact that the psychological processes are of a dynamic character observed via living organism or entity, biological substrate dynamic behavior might postulated that the elements contained within Beck's I.J. linguistic set are of dynamic nature as well as a result of adaptive functions acting related to the above-mentioned input biological substrates, and their indicators will be of a dynamic nature too. On the other hand, they might be quantified via linguistic subset, the content of which is created by elements closely related to adaptive functions, which represent the transformation tools for elements contained within linguistic set to set element content simultaneously. However, the adaptive function functionality is regulated by transformation rules contained within linguistic set as well. The transformation rules and transformation tools create the linguistic set content, and they are re-denoted as transformation operands, and both the subsets create the RD2-SINT partial reference database. The RET-IJ linguistic set. When looking at linguistic set, you can see that it consists of two subsets, while each of them contains adequate number of elements, where appropriate relations might be observed, while those relations create a content of the linguistic set, and the relation are concerned with interconnection among data contained within subset, content of subset, and with interconnection among data contained within content of linguistic set. However, both subsets create content of RD2-SINT partial database as well. Knowledge representation, theory. An appropriate semantic network structure might be constructed, while that network should enable representing of knowledge concerned with manifestations and behavior of biological substrates with respect to previous considerations, which are closely related to PP processes functionality. The above-mentioned semantic network is being created via four subordinated semantic networks. The first two of them are interconnected with partial reference databases RD1-SINT and RD2-SINT, and the second two ones are interconnected with partial SNW-SINT SNW4-SINT semantic networks. Knowledge representation, example. The previous section deals with knowledge representation from theoretical point of view, and that approach is closely related to knowledge-based support of psychological processes, while this section deals with an appropriate example as well, while the research work results published in 15 represents an outgoing material for those purposes, and adequate linguistic sets content within PBPL equation will be assigned to the PET-IJ linguistic set. The PET-IJ linguistic set contains two subsets. Content create data related to maximal work performance within adequate weekdays, and they seem to be input files, while adequate input files are being specified via table 4.1, while data had been calculated with use math statistic 16, application programs 17. However, the above-mentioned files create content of appropriate reference databases and correspond with set content as well, while their content is stored within RD's 01_02 reference databases as well. The PET-IJ linguistic set. The similar way might be applied when making records related to adaptive functions, indicators, and appropriate transformation rules and transformation tools linguistic sets. The TBEX IJ linguistic set. The adequate outputs might be generated when applying predefined transformation rules and tools to the above-mentioned inputs, and they are being stored within and subsets, while the linguistic subset content is represented by indicators related to PP process working performance, and the linguistic subset content is represented by indicators related to PP process working performance status. The RET-IJ linguistic set. The TBEX IJ linguistic set contains indicators concerned with PP and appropriate biological substrates. However, there are specified relation among indicators, and the data concerned with them create content of RET-IJ linguistic set, while it consists of two subsets. However, linguistic subset content is created by indicators representing relations among work performance and productivity indicators, and linguistic subset content is created by indicators representing relations among biological work performance and productivity indicator status as well, while formula 4.6 might be postulated. A short discussion. The The psychological processes represent an individual group of processes derived from psychology related to all living organism and entities. They are much different when comparing them with natural, social, or economic processes, in spite of that they are closely related to PPs. However, they have their own vertical and horizontal structure and require an appropriate information and knowledge-based support from their optimal functionality point of view as well, while they are derived based on living organism and entity behavior, which is conditioned by biological substrates, which create their integral part. On the other hand, they have their own internal and external metrics, which play a role of principal importance when providing their quantification and modeling. However, the psychological processes are closely related to communication among living organisms and entities, and they participate at social, cultural, and historical processes concerned with living organisms and entities. Therefore, all the above-mentioned categories and factors should be respected when providing their quantification and modeling, while math apparatus based on linguistic sets and operands closely related to process linguistic modeling approach, when considering their horizontal and vertical structure, metrics as well as information and knowledge-based support, where semantic networks and reference databases play a role of principal importance. With respect to the above-mentioned facts, an appropriate conceptual model might be designed and implemented, while semantic networks and reference databases are being implemented via RDF files and adequate queries, which create an integral part of graphic databases and ontotext development tool. What we have achieved and how to continue. The psychological process problems represent a core objective of that contribution, and underpinning their structure and functionality aspects together with the metrics and information and knowledge-based support was the main goal of that contribution, while the knowledge representation concerned with psychological processes, which determine external manifestations and behavior of living organisms and entities, play a role of principal importance, and they might be quantified via adequate linguistic sets and PPPL equation. When considering practical point of view, the represented knowledge might be stored to knowledge base, which creates an integral part adequate knowledge-based or expert system, which might be applied when providing evaluation of research results and discovering new primary knowledge. The presented contribution creates basis for design and implementation of adequate application programs, which might be applied when evaluating the research data and activities concerned with psychological processes and discovering new knowledge based on existing one. However, those activities are closely related to research works, which should be provided in the near future as well.
About myself, I've completed both my medical training and my neurology residency in Saudi Arabia. I just recently finished a 2-year fellowship at Sunnybrook Hospital in Toronto, part of University of Toronto affiliated hospital. And I also hold an expert designation in stroke care from the Canadian Stroke Consortium. And I'm on my way to receiving the scholar designation as well. And I hope you enjoy my presentation today. So I'll be presenting a physicians in training perception on the utilization of neurosonology in the management of neurovascular patients. Neurosonology is a dynamic and ever-evolving field. It is a great adjunct diagnostic tool for assessment of the neurovascular patients. I've been lucky during training in neurology, neurosurgery, stroke, and critical care trainees have had limited exposure to neurosonology. So during my fellowship training, I was lucky enough to experience firsthand the diverse applications of neurosonology. This allowed me to further understand and appreciate the many ways that neurosonology can be utilized in these patients. Just to view applications that extend through neurosonology, but are not limited to that, are extracranial vessel assessment when assessing carotid stenosis, subclavian stele. We also can look at intracranial vessels with transcranial Dopplers, we usually look at sickle cell disease patients and ICAD patients. Transcranial Doppler with microemboli detection has been shown to have a great sensitivity and specificity in detecting PFOs, and we also use them to further stratify the risk of stroke associated with carotid stenoses that don't meet the criteria, the guideline criteria for revascularization. So I had the pleasure of working with Don White, which is one of the amazing neurosonology techs in the center where I trained, and Dr. Christine Hawks is a dual-trained stroke neurologist and neurointerventionalist. We both worked on looking into the perception of neurology, neurosurgery, and critical care fellows' perception of neurosonology and management of neurovascular patients. So, like I mentioned before, neurosonology can be used for extra and intracranial neurovascular disease, and its applications have been well established in both the emergencies and secondary prevention. However, the applications and utilization of this technology remains variable among different institutions and physicians as well. In this study, we aimed to study physicians in training's perception about the value of neurosonology in treating such patients. Well, initially, during my fellowship, we started with our critical care fellows, and by applying a questionnaire using an application that utilized a barcode. Unfortunately, the data could not be used as there was issues that arise with the application. So we decided to change the format into an in-person format. We arranged for didactic sessions for our neurology residents, including juniors to seniors. It consisted of a pre-lecture questionnaire, the lecture, which is basically intro into neurosonology, and a post-lecture questionnaire to assess if there was any change in their answers. So our methods, it's a cross-sectional study, as I mentioned, via questionnaire, targeting neurology trainees in neurology, ranging from R1 to R5. It was a 10-question questionnaires. It was shared with them in person, and it was completed prior to and after the lecture. This is just a copy of the questionnaire. As you see, it ranges between, it's a yes and no, and these are the 10 questions. So they consist about the principles of neurosonology, acquisition of imaging, interpretation of these images, and the influence it has on the care of neurovascular patients. The questionnaire data was then collected and analyzed pre and post lecture. 15 residents were completed the two-part questionnaire. What we noted that the average yes answer response changed from 4 pre-lecture to 9 respectively. And we also noted that the significant improvement in post-lecture yes responses were found in the most senior and the most junior levels, as I'm going to show a graph of that, in the R5 level and the R2 level. So figure 1 shows the pre and post differences in yeses among all trainees. And this figure shows that the main change in yes responses was among the R2s and the R5s. R2s are just starting training in neurology, and R5s are just finishing their training. So our conclusion was our small cohort did demonstrate that among residents in training, there is a lack of awareness about the full scope and indications and applications of neurosonology in neurovascular patients. Our future plan, we do acknowledge that further future work is needed to study the effect of incorporating a practical neurosonology and its curriculum and its influence on the management of neurovascular patients. We're also planning to do this questionnaire on a bigger scale to include neurosurgery residents, critical care residents, as well as its internal medical residents. Thank you very much. I don't know if there are any questions or
on the works of Sri Aurobindo and Patanjali. And in this book, The Synthesis of Yoga, Sri Aurobindo affirms that unity results from the initial movement on the path of knowledge. And he's going to justify this, affirming that there is a leap that transcends the realm of illusion, and illusion is the material existence, the world of our senses. This material existence of material things does not truly satisfy us. He's going to affirm this, leaving us with two alternatives: either embark on the pursuit of unity or resign ourselves to the feeling of absence and seek temporary fulfillments. The basis of this affirmation is that we feel a lack of something, and we try to fulfill this lack, and this fulfillment will have these two alternatives. The challenge of this way of thinking is our Western scientific thought, which seeks evidence and proof in the world of sensory experience. I know that, and I have heard some of the presentations here that present the results of the research. And this is one of the difficulties, because sometimes we cannot prove what we feel or what we have the intuition of. The first step to surpass this difficulty is to overcome this difficulty. Is this affirmation that it's necessary to listen to what our intuition, soul, or consciousness tells us about this lack or absence or incompleteness that we feel. But we are naturally drawn to the multiplicity, because this multiplicity is what we immediately see and what we immediately feel. So, if we can listen to our intuition, we can surpass this difficulty. There is a duality, of course, and in this philosophy, the affirmation of this duality and unity is have this correspond to these names, these concepts of Purusha and Prakriti. Purusha meaning the soul, and Prakriti meaning the material world. Então, Purusha, so then, Purusha and Prakriti correspond to the two elements of living beings, nature and soul, with activity relating to nature and freedom to the soul. So activity is related to the material world, and the soul corresponds to freedom, to our capacity of choosing and understanding. This duality is evident through experience and religious, philosophical, artistic, and scientific manifestations. All these activities are attempts to address the problem of our existence. So what these philosophers affirm is that all these activities have some evident or are in these activities we have evidence of this duality in religious activity, philosophical, and etc., even in scientific manifestations. So this theme of union is inscribed in the very nature of yoga. So now we are going to talk about this activity that makes possible to attain this unity that the philosopher is talking about. So yoga and union in this theme, we see that the practices that compose yoga aim to lead us to the awareness of this union. All the practices. So we are talking about exercises and breathing and concentration. In Patanjali, we find this definition that yoga is the restraint of the modifications of the mind. Modifications of the mind are said to be of 5 aspects: correct knowledge and erroneous knowledge, imagination and sleep, and memory. These are the 5 modifications of the mind that appear in Patanjali. So if we are aware of these modifications of the mind, the practice of yoga is going to silence our mind to find what is the fundament or is behind all existence. Of course, that our society presents another difficulties to this practice, because we are always, as we are now, hyper-connected and excessively stimulated by all the equipments, cell phones, computers, and etc. And we have to realize that the presence of all these stimuli have an effect on our memory and perception. It's not the case to demonize all these equipments, but to perceive that they have this effect on our perception and our memory. We are going now to emphasize practice and experience. Also in Patanjali Yoga Sutras, he presents these 8 components of the practice that are yama, code of social conduct, niyama, code of personal conduct. These 2 first are the basis of all practice. You have to be pure, and you have to act morally. Third component are the asanas, the physical or psychophysical postures that help us to better our the relation to our body. We have consciousness about our stress and our difficulties. Number 4 are the pranayamas, respiratory techniques of mastering bioenergy that help us also to be more relaxed in a way that you can have a consciousness of your body. Pratyahara are the techniques for mastering the mind and emotions. These techniques are the training of our how can I say, for you to not to feel all the sensations. You keep distance of all the sensations and emotions. Number 6, oh sorry, there's a mistake here. Number 6 is dharana, concentration, and dhyana, meditation, are the last components of practice that you are going to attain if you dedicate to the practice of the other 5 or the other 6. In this paper, it's not going to be possible to talk, to present all the results I have attained in the classes I give. I didn't say at the beginning, but I am a teacher of philosophy, and I am a teacher of yoga too. So in our practice, and generally the people that look for yoga classes are focused on these 2 aspects, asanas and pranayamas. People like to look for yoga for to have a better functioning of the body, to relax, but yoga is not only that, but I'm going to focus only on asanas and pranayamas and some aspects of pratyahara. Asanas and pranayamas, this practice, are more concrete and yield more immediately observable results. We can see in the practice of people that they are having more conscious relation to their body. They get to know what their limitations are and what are their pains. The latter, or the pratyahara, should lead to the practice of concentration and meditation, because you can only concentrate if you turn off your senses in relation to the outer world. These physical aspects can transmute into the psychic trait, as emphasized by Carl Gustav Jung and Sri Aurobindo. Practical aspect emphasized by Aurobindo and Patanjali, and psychological aspects related to the practical aspect can also be observed in the practice of yoga. The author, called Paranjipe, analyzes concepts from yoga and psychoanalysis. He makes a relation of yoga and psychoanalysis to indicate the harmony between the practical aspects of yoga and the scientific validation of Western science. To attain the contemplative state, the meditator gradually distances themselves from objects. This is the pratyahara, the practice that I have said before. And the author Patanjali describes this process as a series of experiences undergone by the meditator, wherein they progressively distance themselves from the usual cognitive experience. This means that beginning with the practice of asanas and pranayamas, you gradually learn to distance yourself from the outside world and get in touch with your interior, where you are going to have the intuition of something that can be proven, that can be shown, or cannot be proved by experience, by scientific experience. All this practice is going to produce this detachment that, according to Patanjali, occurs in the following order. First from smell, then taste, sight, touch, and hearing. So you are going to get detached from the outside world in this order, according to Patanjali. So first you are not going to be stimulated by smell, then taste. Of course, this happens in the practice, and it's not going to happen that the person is going to lose all these capacities, but it is the practice and this that is going to produce this during the practice, during concentration. And this order, affirms Paranjipi, is the, and also Patanjali first, is the reverse of their creation during the course of evolution. I have to say here now that Patanjali, philosophy of Patanjali is logical. It's called Samkhya, and Samkhya describes the order of creation. There is a logical order of creation, and in this case specifically, this order would be then hearing, touch, sight, taste, and smell. So when you begin to lose or to get detached from these senses, the detachment happens in the reverse order. And this reverse order is called Pratiprasava, that's translated by Paranjipi as regression. So he makes the relation of these techniques of yoga with psychoanalysis that has this technique of regression. But in psychoanalysis, regression refers to trauma in childhood, for example. But this regression is going to take to another place, that is the place of the intuition of what comes first or before life. And this outcome can be known, understood, and proven, as stated by Vyasa, that is a commentator of Patanjali, in the practice of yoga. So if there can be any proof of this movement, the proof is in the practice. So you have to begin practicing to see the results. There can be no proof before that. Or we can say also that as yoga has, as the old books say, 10,000 years, so this proof has already been done. in this practice, so the Aurobindo is going says that this process it refers to this process as regressing to find the unity, the origin of the multiplicity we experience. So unity is the origin of this multiplicity. You have the unity in the beginning, or not only in the beginning. Unity is now, is present. So first we have unity, and then we have multiplicity. And this process of regression is going to take us to the experience of what is before multiplicity. He also affirms that a profound restlessness impels the seeker towards a path where, without succumbing to resignation, a continuous advancement is assured, leading one from the present state to the very source. So if you have this this feeling that something lacks, you are going to look for what can fulfill this lack. So you continue looking for. You don't stop. So the relationship of the practice of yoga and mental health. So here I refer to my experience with my practitioners that initially seek yoga for various reasons, for physical health, flexibility, relaxation, stress reduction, and spiritual quest. This is the last reason why they look for yoga. The demands and conditions of the practice will eventually lead these practitioners to the realization that it goes beyond purposes related to physical or mental well-being. So the proper practice is going to show to these practitioners that these reasons why they are looking for yoga go beyond what they are looking for. They are going to realize that there's much more to discover and to find out. What happens is that some people remain with the hope that they are going to achieve these results, but some people run away from it because they don't want to face these results, because this is what is going to put some doubts and questions on what they are living. You have to want to change. You have to want to face what, these results are going to show you. So the philosophy underlying yoga, as practitioners become aware, demands discipline, that's called tapas, to achieve a deeper purpose. This realization, in turn, leads to self-awareness. Still, the relationship between yoga and mental health. So if these practitioners are open to go beyond, they will recognize their physical limitations and their relationship with unconscious traumatic situations while practicing asanas. Asanas are psychophysical positions that show us not only our physical limitations, but our tensions. And these tensions have psychic or emotional reasons. The practitioner also may become aware of their emotions and learn to manage them better through the practice of breath control technique. Up to this point, yoga and psychoanalysis go hand in hand. Both look for or search the same results. It's necessary to emphasize, though, that this practice does not intend to distance us from the world, but rather to have a balanced relationship with it, to accept it, to know it, and to deal with it, but not to I am not proposing a monastery life. It can be chosen, of course, but it's not my aim. I complete here so that we can overcome the separation between matter and spirit, a separation present in both science and religion. Science deals only with matter, religion deals only with spirit, and yoga means union of matter and spirit, because everything is spirit, everything is matter, everything is connected. So I get to my final considerations. My aim here was to establish a parallel between the practice of yoga and psychoanalysis. It is a synthesis of the work I have produced. According to yoga, afflictions should be reduced by reabsorbing them back to their origin. So we have to go back and understand that some of these afflictions come from the not recognition of our spiritual aspect. This means that the afflictions do not cease to exist, but become inactive, and the practitioner sustains this state through continued practice and attention to potential causes that could allow them return. Thank you very much. If you have any questions, you can ask and I will try to answer them.
Thank you very much, Dr. Sonia. That was a very interesting presentation. Does anybody here want
of SLE in Saudi Arabia and their associated factors or variables? So to begin with, SLE is an autoimmune disease which the immune system targets the connective tissue of the body, causing a huge effect in each part, which damage their function and causing a broad spectrum of symptoms, which include the neurological and psychological symptoms. We have in Saudi Arabia, there's actually a huge gap in this field, so that's why we decided to build this article. So this article aimed to establish or to know the prevalence of a neuropsychiatric manifestation of SLE in Saudi Arabia and also the variables that are linked to it. Regarding the methodology of this study, it's a cross-sectional study with contribution of the Saudi Rheumatism Association. We use their social media platforms to spread our questionnaire. It was an online questionnaire among we spread it among all SLE diagnosed patients in their society in Saudi Arabia. So we have included both genders who lived in Saudi Arabia and who are above 18 years old. And we exclude all other criteria. So the number of the study sample for this study was 335 patients in the Saudi who are in the Saudi Rheumatological Association, but only 205 were responded to the survey. So our questionnaire was consisted of two parts. First one, it was about the demographic data. And the second one about the presence of, the second part, it's about the presence of neurological and psychological manifestations. About 25 questions. It was adapted from another article, which was by University of Pisa in Italy. So طبعا the questionnaire validity was assessed by a professional translator with a contribution of 2 consultant rheumatologists and an expert in our university in rheumatology research field. So to continue with, for the result of the study, out of 205 participants, 91% of them were females, 13.5 had a positive family history of SLE, and 26 was diagnosed in the last 3 years and less. What we know that the most common from our study, the most common reported symptom among patients was alteration of sensation, followed by, with a percentage of 53.4, followed by fear, headache, with a small differences from the alteration of sensation, but the headache have been described as a prominent symptoms in several other studies, not only in our study. The least common reported symptom was meningitis sign. One of the findings of the study was the neuropsychiatric symptoms were more in patients with the neuropsychiatric symptoms was more in patients with comorbidities like diabetes and hypertension, more way than the patients without any other comorbidities. Also, we reported that the neuropsychiatric manifestations were more in a patient with positive family history of SLE. All these regardless of their age group, marital status, educational level, or the duration since the diagnosis. On the other side, actually, we have some limitations. One of them that there were some confounders that may develop from other chronic diseases, or some symptoms that may develop from other chronic diseases, not from SLE. So, or as a side effect from the medication. So this was one of the limitations. The second one, there was some recall bias from the responder when they answering the questionnaire. So this is also one of the limitations. The last one was that our targeted population were from we targeted all the SLE patient diagnosed in Saudi Arabia, but actually it was only who are in the Saudi Rheumatological Association, not so there was some patients out of the society that we didn't know how to contact with them, so we didn't take their answers actually. So this was also one of the limitations. As a conclusion for our study, nearly half of SLE patients are experiencing neuropsychiatric manifestation, so more than half. So it's important to understand the strong association between the neuropsychiatric morbidity and other relevant traumatic disorders in SLE patients. So this is the end of my presentation. Thank you for listening, and that's it. Thank you so much.
Thank you so much, Dr. Lujain. That was a wonderful presentation. Does anybody have any question for her?
Telephone cognitive assessment tool. So with these are the contents of the presentation, and I'm going to start with the problem. So with the development of vaccination strategies and the social distancing measures, the rates of acute presentation of the disease have decreased. However, it has been seen that in some patients, symptoms such as cognitive dysfunction, headache, and weakness persist over time, and today are a frequent reason for neurology consultation. So up to 80% of patients after the infection complain of cognitive symptoms, the most frequent being memory impairment, difficulty in concentration, and also attention compromise. So with this information, we aim to consider that if they persist in the long term, cognitive difficulties will have a transcendental impact on the quality of life and social performance of more than 600 million people who survived the SARS-CoV-2 infection. Additionally, life expectancy is increasing globally, and also the prevalence and incidence of neurocognitive disorders. So we decided to ask ourselves the question of whether or not COVID-19 is another reason for us to worry about the cognitive future of our society. So the research question was, what is the impact of SARS-CoV-2 infection on the cognitive performance of the recovered patients 1 year after the infection when compared to uninfected patients? The general objective of our investigation was to estimate the association of COVID-19 infection with the development of cognitive impairment using the MoCA-T or Montreal Cognitive Assessment Test performed over telephone 1 year after the hospital discharge. Among the specific objectives were, first, to describe the sociodemographic and clinical characteristics of a cohort of patients who were infected by SARS-CoV-2, to determine the cognitive performance of patients with COVID-19 by applying the MoCA-T 1 year after hospital discharge and in a cohort of patients without history of the infection, and also compare the presence of cognitive symptoms and MoCA-T results between cohorts with and without a history of COVID-19. So this study was carried out with the design of an observational, analytical, and prospective cohort study, which was approved by the Medical Ethics Committee of the university and the institution where the data were taken. Patient selection was carried out from January the 1st to 2021 to the August 31 of 2021 using our collection format, which include the sociodemographic and clinical information of the patients. 1 year after the discharge, that is from January the 1st to August 31, 2022, the MoCA was applied and the non-COVID cohort was selected from the 1st of August and the August the 30, 2022, a period in which the tool was administered to the cohort with no COVID history. Patients between 18 and 65 years of age who agreed to participate in the study were included, and the infection has to be confirmed by PCR or immunoglobulin, okay? And or psychiatric disorders. Patients who died or who had any tech limitation in performing the MoCA-T were excluded, and the non-COVID cohort was selected from caregivers of ambulatory patients select of any specialty with at least one negative COVID test and who were asymptomatic during the last month. For the analysis, we perform an univariate analysis by determining absolute and percentual frequencies as well as all the median and interquartile rate. The contrast of hypothesis was carried out using the chi-square or Fisher test and the Mann-Whitney test to determine the association between the infection with poor cognitive performance on the MoCA test. The relative risk was estimated and a Poisson regression model was used to control confusion. And our results were the following. 100 patients with COVID-19 were selected and 30 of them did not participate in the study according to the exclusion criteria. The COVID-19 cohort study included 70 patients and the non-COVID include 68 patients. 50% of COVID patients were aged 45 years or older compared to 29 years for not COVID-19 patients. In both cohorts, the male gender was predominant, and regarding education, the minority of patients complete primary school and the majority had higher education. The most frequent condition and comorbidity was hypertension in both groups, and we found significant difference in both cohorts in terms of age, postgraduate educational level, and hypertension. These variables were included in a covariate analysis. So the majority of patients infected with SARS-CoV-2 had a severe infection, that is hypoxia less than 94% of oxygen saturation, need for supplemental oxygen or ventilatory support, tachypnea, respiratory distress, or involvement or compromise of more than 50% of lung parenchyma. And more than 40% of patients with a history of COVID-19 report cognitive symptoms up to a year after the infection, compared to 8.8% of patients without COVID. But what were the symptoms? The symptoms reported by patients with COVID were loss of memory, difficulty in concentration, and anemia for both cohorts. After we applied the MoCA tool, we found that 50% of patients in the COVID-19 group had performance of less than 18 points, which suggests mild cognitive impairment. And the majority of these patients had a score between 15 and 20 points, while in the non-infected group, in the non-COVID cohort, 50% of patients had a superior score than 20, and with an interquartile rate between 19 and 20 points, which indicates that more than 70% of these patients had adequate performance in the test. It means, as you can see in the graph, that more than 60% of patients with a history of COVID perform poorly on the MoCA tool, compared to 19% of not infected patients. When doing the analysis by domains, we found that there were statistical significant differences between the two cohorts in performance in attention, language, executive function, and memory. Orientation was not affected in either cohort. Okay, attention, language, executive function, and memory loss. So potential confounding variables that showed statistical significant differences when comparing the two cohorts were selected and subject to a Poisson regression test. When this bias were controlled, only COVID-19 infection showed a significant impact, demonstrating that infected patients perform worse on MoCA-T test when compared to uninfected patients. We made a stratification, and it was found that severity of the infection negatively impact on the cognitive performance of patients compared to a mild or moderate infection. So to analyze these results, we start from what evidence exists on this topic. It was previously reported that up to 81% of patients present cognitive impairment during the acute phase of the disease and after 12 weeks or 3 months of infection. These symptoms and objective evidence of worse cognitive performance persist in up to 65% of patients. And in Wuhan, a study report that of a cohort of patients evaluated, they report an incidence of 9.1% of patients with cognitive impairment at 12 months and 3.3% of patients with dementia after COVID infection. However, here in Colombia, we found that 61.4% of the patients evaluated present poor cognitive performance in the test, with statistical significant differences compared to the non-COVID group. So we conclude that COVID-19 infection is associated with worse cognitive performance at 12 months of follow-up, that the subjective deterioration is predominantly memory and attentional, and performance in screening tests such as MoCA-T shows greater affection in the domain of language, attention, and memory. We are reporting here new information in the dynamic change in cognition of patients who survived to coronavirus, suggesting a possible substantial contribution on the pandemic to the burden on neurocognitive disorders expected in the future. And finally, calling for cognitive screening strategies and make a prompt diagnosis and identify patients who could be candidates for early rehabilitation therapies. Finally, we can see the limitations of our study, which in turn may motivate similar investigations that may include a larger sample and allow the administration of neuropsychological tests to confirm the diagnosis and severity of the cognitive compromise. So thanks very much for your attention.